And I'm very glad that to kick off this session, we have Yee-Chun Chen, who is a professor at the University, National Taiwan University. She's an established infectious disease physician in Asia with multiple interests, not only in mycology, but also in infection control. Has made many contributions to mycology in Asia. And yeah, we're just very happy that Yee-Chun will kick off the second session of the morning. Okay, Yee-Chun.
Thank you, Professor Tan's introduction. The second section includes 3 tiers. The first tier, I will focus on the clinical risk factor who are at risk. Then we have 3 speakers focus on more microbiology. Then the third tier will be how to manage. The disease burden of invasive candidiasis remain high. According to multi-state points prevalence survey in United States show that Candida were the leading pathogen causing healthcare-associated bloodstream infection in acute care hospital. Also, the data based on national surveillance of healthcare-associated infection in the ICU in Taiwan and Korea show that Candida are common pathogen causing healthcare-associated bloodstream infection. According to our previous large-scale surveillance in Asia, patients from ICU contribute 23% of the candidemia cases as a whole. As we know that candidemia was associated with the very high in-hospital mortality. This large-scale surveillance in Asia showed that the hospital-wide incidence of candidemia was 1.2 per 1,000 discharge, very widely between different hospitals or even countries. When we take a close look, we can see that the incidence in ICU about 10-fold than the hospital-wide data. We can see why this data vary by hospital because there's a mild correlation between the incidence of candidemia and the ICU versus total hospital bed ratio. Therefore, if your hospital has many ICU beds and taking care of very critically ill patients, then you might have more opportunity to taking care of patients with candidemia. Candida is a perfect pathogen. It can be a very benign colonizer, and it can cause superficial infection, or sometimes when the host become compromised, either immunology, systemic immunity, or mucosal immunity, or some physiological change, the Candida may become systemic infection, including candidemia, or involve some deep organ. For example, this is a brain abscess. This is a IVC thrombosis in a patient with persistent candidemia albicans. This is a pregnant woman have septic abortion, and immediately after delivery, he had fever and had candidemia and endophthalmitis. This is acute leukemia. Following induction chemotherapy, he had persistent fever. While the neutrophil count recovery, he complained of upper abdomen discomfort, and the imagery CT showed that microabscess in the liver and the spleen. Where are they come from? The majority of Candida are endogenous. The organisms are part of our normal flora, including skin, gastrointestinal tract, airway, or female genital tract or urinary tract system, especially with indwelling Foley catheter. But sometimes the patient get infection due to exogenous Candida may come from the skin flora of their healthcare worker, or from food, for example, Candida cruzi and other rare Candida species. In recent years, we know that Candida auris may come from the contaminant healthcare environment as well. Many years ago, we do active surveillance in ICU adult patients with expected ICU stay. And we do active surveillance and found that 2/3 of them has one or more Candida colonized. And during the follow-up, 1/4 of them developed invasive candidiasis. And 2/3 of them can identify colonization before infection and due to similar or identical Candida isolate. However, as you already discovered very interesting to know that not everyone with Candida colonization will develop invasive candidiasis during the follow-up. Based on our study, you can see that up to almost half of them had Candida albicans colonized, but only less than 10 among this population developed Candida albicans infection. The proportion might be higher for Candida tropicalis colonizer. Nevertheless, not all of them developed invasive infection subsequently. Why? Why some of them developed infection, but some of them just colonizer? We take a look for this real case. This elderly gentleman with non-small cell lung cancer at right middle lung and a step post operation 3 years ago, now recurrence and obstruction and received concurrent chemoradiotherapy and with esophageal stenosis and collapse of right lung. He complained of dysphagia, choking, and automental status, and a fever for 1 day, and sent to hospital and admitted to ICU, and treated with tazocin empirically. And at the same time, he has insert a central line and start total parenteral nutrition. Fever subside, although blood culture was negative, but 5 days later, spiking fever developed again. And the next day, the blood culture report Candida albicans from peripheral blood as well as from central line. It seems very familiar for all of you. There's multiple risk factors: cancer, mucosa damage, central line critical ill, and parenteral nutrition, and prior infection and using antibacterial. Therefore, not all the ICU patients are the same. The incidence of candidemia varies by underlying disease. This is our hospital-wide population study demonstrate that per 1,000 patients with this diagnosis, the incidence of candidemia vary widely, very high for GI malignancy than other solid tumor, very high for patients with renal impairment. So not all ICU patients are the same. They are heterogeneous in their underlying disease. We can take not every patient, as I mentioned, not every patient is ICU patient, and not everyone is cancer patient. Take this case as an example. This woman has poor control diabetes and cirrhosis liver. He had vomiting, diarrhea, and acute renal failure, and was hospitalized in a hospital ICU. He received dialysis and renal function recovery gradually. 2 days after discharge, family found she had tremor, seizure, and loss of consciousness. Therefore, he readmitted, and the image showed that there's a brain tumor. Therefore, she was transferred to our hospital under the impression of brain tumor. However, patient family hesitated to conduct craniotomy, so delayed for several days. After craniotomy, the pathology and the culture confirmed the diagnosis is brain abscess due to Candida albicans. This is an unexpected finding in a so-called community not from our hospital and already discharged from another hospital. But she has several risk factors of invasive candidiasis. This is a large-scale retrospective study at our hospital demonstrates that some of the candidemia occur in the community. Therefore, when they visit ER or admitted, physicians are very likely underestimate the possibility and the risk of candidemia. According to the epidemiology, we can classify into several truly community acquired, and some of receive healthcare. Almost only less part of patients are truly community acquired. Half of them, they just recent discharge from the hospital, is our case too. Others are receive some invasive procedure or indwelling catheter. Therefore, physicians should be alert even patient present at ER or from the community or transfer from other hospital. The underlying disease, you are familiar with cancer, hematology, but I emphasize that diabetic patient and cirrhosis liver and the repeated urinary tract infection due to urinary tract obstruction, because specialty they are not familiar with candidemia, and it's relatively rare in diabetic or cirrhosis patients. Therefore, the risks are very likely underestimated, therefore associated with poor outcome. However, you can see a lot of intervention for this kind of patient, including immunosuppression therapy, neutropenia, steroids, GI bleeding, receive H2 blocker or proton pump inhibitor, or antibiotic, or total parenteral nutrition. All these were causing dysbiosis. Following more and more cumulative data for epidemiology, several investigators generate the Candida prediction rule to emphasize to be aware of what patients are at risk of invasive candidiasis. You can see two of them emphasize the colonization. Others are purely clinical risk factor. Among various clinical factors, you can see the antibiotic use, central line use, total parenteral nutrition, or other. Based on different studies, large scale, small scale, multi-center, multi-nation, they give different prediction rules. And many of them are difficult to validate in different countries or different hospitals. This compromise the clinical implementation, or some of them too complicated to implement in daily practice. Some of them, for example, Candida score and the Candida colonization index depends on antimicrobial surveillance. It is not part of our clinical practice and the resource intensive. Among them, Candida score are easy to use, very famous, just because very simple, 4 factor. And based on multivariate analysis, they give the score 1121. If a patient with Candida score more than 2.5, they are 7 times as likely to have proven candidiasis than those without high score. This study, the sample size is large and validate later, demonstrate the score are useful in their patient population. However, as you heard, Professor Aaron has emphasized that if you use this Candida score, you are very likely overuse antifungal in your patient population. We can take a look. This paper published many years ago, but very important. They emphasize that based on literature review, we can see the risk factor for multi-drug resistant bacteria, Candida, Clostridium difficile, shared common risk factor, including a lot of factors impair patient immunity and using of antimicrobial agent intervention. So it is very important. Restrict or rational use of antibacterial. Now also emphasize the importance of antifungal stewardship, as well as infection prevention and control. Otherwise, we're facing the crisis of antibacterial resistance. Now we have Candida or other fungal pathogen with antifungal resistance. This is not new. The birth of antibiotic regret. The author published the data as a perspective in 2012 using this very strong term. This is back to 1953. They point out the antimicrobial agent disperse the ecology and causing the fatal fungal infection, complicate patient receiving antibacterial therapy. We can see, as this author, this is a kind of disease of medical progress. This is a reason why we have very interesting discussion regarding how we can use antimicrobial agent smartly at right patient and at right time. Back to the ecology. Now through the microbial study, we can take a look. This kind of study began at the beginning of antibiotic era, but the majority of scientists and physicians neglect the message. But now be aware, just because microbiota study, you can see this is a healthy microbiota and a dysbiotic microbiota. For gut microbiota, dysbiosis is induced by antibiotic-mediated depletion of bacteria or genetic defect in antifungal immunity, change in diet or use of antifungal agent, or mucosa inflammation, such as inflammatory bowel disease. You can see the distribution or from the increase of ascomycota, especially increase of Candida. This is a reason why in a healthy condition, we have Candida colonized, but in low amount, while the dysbiosis, we have more and higher amount. So in conclusion, who are at risk for invasive candidiasis, we can classify into 4. Immune impaired, either systemic or mucosa immunity impairment due to underlying disease or later intervention, invasive procedure, or other healthcare factor, in addition to the antimicrobial use or other causing dysbiosis. Of course, now we're more aware, as Professor Lee's professional, CAR-T deficiency in otherwise healthy adult, but have unusual fungal infection. So how to incorporate this kind of clinical prediction rule? For example, for patients at risk of invasive candidiasis, either ICU or hemato-oncology patient, we can integrate this kind of prediction rule in our practice to identify higher risk patient, especially take into account of the severity of the illness. If the risk high and the critical ill, when we see the patient, we may aggressive diagnosis as well as empirical antifungal therapy. After microbiology confirm, we switch to definitive therapy or de-escalation. Otherwise, patient is stable, but risk is high. We can initiate diagnosis and decide whether we initiate definitive therapy or biomarker-guided preemptive therapy. Otherwise, we can cross-observation and more aggressively to modify the risk factor in order to prevent invasiveness. In addition, time is very important. All the risk factors did not emphasize the time. This is the first, I think, very important, although very small scale. They emphasize the duration between colonization index above 0.5 and the developed subsequent infection was 6 days. This is very magic number, 5 or 6 days, especially if patient, the risk factor persists. Within 6 days, if patient become better and all the risk factor resolve or remove, then this patient very likely will not develop invasive candidiasis. Otherwise, he continue use antibiotics. They remain the high Apache score, remain or more Candida colonization, then this patient are very likely that subsequent infection will caused by Candida. In addition to the risk, what kind of antifungal agent? Not only consider the risk and the likelihood of infection, we need to take into account of the antifungal resistance, especially the first-line use. Therefore, the author take this cost-effective analysis and demonstrate that if the risk of infection and risk of resistance is above certain threshold, then you may consider use the empirical use of echinocandin. At that time, only caspofungin are available in United States and very expensive one, but it's still cost-effective based on this study. On the other hand, for low risk, low prevalence, or very likely no prior use of azo, then we can use the culture-based initiation of fluconazole. I would like to propose another challenge. This is disseminated candidiasis due to Candida tropicalis in a young adult with acute lymphocytic leukemia. You just take a look. Following chemotherapy, they have blood culture of Candida, persistent candidemia, the skin metastatic focus, and the paraspinal osteomyelitis, and this is renal. This is a day, morning 100 days after the first positive blood culture. It remains Candida. So not just by risk, by other antifungal resistance, we need to consider the cyto drug in patients with impaired immunity or risk of bioinflammation. Hepatosplenic candidiasis or other fungal infection are very difficult to confirm, despite of very aggressive, at that time, with very aggressive blood culture and the liver biopsy. The yield rate are very low, but difficult to treat and with protracted course. Facing the azo resistance, Vietnam has, this is from different country. This is a multi-center study. This is a proportion of tropicalis among candidemia. This is a susceptibility of fluconazole. in Candida tropicalis. So we should be aware, not just Candida glabrata may associate with other resistance, should be aware of Candida tropicalis because Candida tropicalis are important in tropical Asia and tropical America. And we just recently published this data. I just urge your attention because a certain proportion of them have almost pan-azole resistance, and half of them are not received or exposed to azole in the preceding 6 months. They are azole naive, but in fact, by pan-azole resistant Candida tropicalis. And all this chronology could be identified in different cities, different households in Asia Pacific region. This is my presentation. Thank you for your attention.